Dr. Eric is a thoracic and cardiovascular surgeon. He is presently a consultant of the Department of Surgery at the Medical Center Manila and assistant professor at the Emilio Aguinaldo College of Medicine in Manila. He was formerly a consultant and assistant professor in the Department of Surgery de La Salle University Medical Center, Philippines. He graduated from the University of the Philippine College of Medicine and had internship training and residency in general surgery and thoracic and cardiovascular surgery at the Philippine General Hospital. He had his fellowship in training in cardiac surgery at the State University of New York or Buffalo General Hospital. Without further ado, Prof, you can continue giving your opinion.
Pleasure and honor to be invited as a reactor in this symposium, and I should say the four esteemed speakers have mostly covered everything we would probably want to know about vascular trauma. Specifically regarding training of general surgeons in vascular surgery. If I may, in my opinion, it's ideal that every general surgeon be properly trained and updated in vascular surgery, particularly, for example, in our local setting here. As you know, the Philippines is an archipelago composed of 7,100 islands separated by large bodies of water and frequently inundated by natural calamities like typhoons and volcanic eruptions and so forth. And each island also has its own intricacies, lots of mountainous areas, poor road networks. So we don't have real ideal networks of trauma systems. No? It's very difficult. We don't even have proper land transportation, even in the metropolis. Much more facilities for, let's say, air transport. So I think it's incumbent and important that general surgeons practicing in the different localities, particularly far-flung areas, be well versed in vascular injuries, okay? Particularly those necessitating immediate care. Okay? Another thing is that we don't have the necessary facilities, resources. So as I would like to cite Dr. Crozier, we are working in sort of austere environment where we have limited resources. In fact, most older surgeons would probably love to tell anecdotal tales about how they manage patients, okay? Sort of innovate in their own way, learning on the job sort of thing. Nowadays, at least the umbrella organization, the Philippine College of Surgeons with its subspecialty societies, including the Trauma Society, as through the efforts of several pioneering doctors, made efforts to standardize training. So that includes, of course, training and rotations in vascular surgery. Okay, so that when these young graduates go back to their areas of practice, at least they will be somehow equipped to be able to handle trauma to a certain extent. Okay, there's still much to be desired, but I would say overall there's been significant progress, together with the availability nowadays, like this one, webinars, of course, because of the COVID situation, but webinars and conferences, at least from the theoretical aspect, young surgeons and surgeons in training would gain a lot, no, from the experts. And with standardization of training before these young surgeons get to be certified and credentials, they would need to have done a certain amount of cases that would prove their adequacy, at least in the field of trauma. Having said that, there's one aspect also I'd like to say. I agree with Dr. Goffard in terms of probably many vascular surgeons not being the best trauma surgeons, but I think it's also a factor of interest. Okay, let's face it. At least here, returns or remuneration from trauma is not that good, and particularly with more senior surgeons, many of them would probably would not want to be awake in the wee hours of the morning where many trauma cases come in, particularly if they're preparing for their morning cases. So it's really up to the general surgeons to take the cudgels, and only when necessary would probably they be calling help. Of course, in major centers, there's always a contingent of specialists who would be around just in case they would need to be called. Again, the general surgeons, here locally, we still don't have that much real pure trauma. Although trauma surgery is slowly becoming a subspecialty, we don't have that much pure trauma surgeons, again, because of the returns. So you'll see most of the trauma surgeons concentrated in the academes, okay? So in private hospital settings where you don't have that much cases, probably you won't be seeing so many trauma surgeons still rely on their general surgery practice also for their livelihood. I think that mostly covers my reaction. Yes, I think so. For me, general surgeons still would probably be better off if they had training and regular updates on vascular surgery for trauma. Thank you.
Dr. Willy Muljono, he's a consultant vascular surgeon in Papua, Indonesia and West Papua, Indonesia. He's a member of the Indonesian Society of Vascular and Endovascular Surgery and Director of Operating Room Management Team in Merak General Hospital in Papua, Indonesia. He's a national faculty of the ATLS course and Basic Surgical Skills course of the College of Surgeons of Indonesia. I will invite him to give the reaction to Dr. Tal Hora's talk on the current state of ROBOA and its applications. Dr. Willy Muljono, please.
Good morning, good afternoon, and good evening. I would like to welcome everybody to our active webinar today. I am Dr. Willy Muljono. It is an honor for me to be the reactor of active webinar representing Indonesian today. Before we begin, I would like to thank the committee for making this webinar possible. Indonesia is a term of geography is very broad, diverse, and has so many variations of the infrastructure in health services facility. Spread over various islands from west to east, I am in the easternmost island of Indonesia, Papua Island. With this difference in infrastructure for its healthcare facilities, the treatment of vascular trauma cases in its care facilities from island to island. In my country, patients with non-compressible torso hemorrhage, damage control for abdominal and or pelvic bleeding, which is life-threatening, are treated with the Reboa minimally invasive procedure. Access to the common femoral artery is essential for performing Reboa. This is a temporary obstruction of the aorta with an endovascular balloon, providing proximal control to the site of vascular injury while supporting cerebral and myocardial perfusion. Reboa significantly increase blood pressure and can reduce the risk of hypovolemia. Distal artery thrombus formation is common and should be actively treated. Everything has been explained in detail and clearly by Prof. Talhorer. I agree. And there is no need to adopt the handling of vascular trauma with the Reboa technique by Prof. Talhorer, same as in textbook endovascular resuscitation and trauma management. In my country, especially in Papua Island, there are many cases of penetrating or blunt vascular trauma that we can find. Penetration particularly is done by sharp weapon, arrow, while blunt trauma is done by traffic accident. In my country, vascular surgeons are few. So, general surgeon, interventional radiologists, and anesthesiologists must have the necessary skill to perform Reboa to temporarily reduce ongoing bleeding with the aim of saving the patient of life. In the urgent cases, Reboa is required within the first few minutes of patient arrival. Not all medical disciplines are involved in the emergency room management of trauma patient. Reboa is not only performed in the emergency department, but also in the operating room, angiography room, and sometimes in the hospital setting. For the future, Reboa procedure should focus on early initiation of Reboa after injury, which may depend on developing rapid vascular access device and technique more than on novel improvement in Reboa and chip. So many patients will be safe. Thank you. Keep safe and stay healthy.
Subohd Kumar from India is a professor of surgery in the Division of Trauma Surgery and Critical Care at Japan Apex Trauma Center, All India Institute of Medical Sciences, New Delhi, India. He is a fellow of Royal College of Physicians and Surgeons, Glasgow, and fellow American College of Surgeons, fellow American Association of Surgery of Trauma, AASC, member of National Academy of Medical Sciences and College of Laparoscopic Surgeon Society, the Vice President of ISTAC, which is Indian Society for Trauma and Acute Care, and he is also an international guest scholar, American College of Surgeons.
Thank you very much for a nice introduction. Good evening to all. And at the outset, I would like to thank the organizers for giving me this opportunity, and especially Professor Ronaldo and So first of all, I would like to congratulate all the speakers for they covered the important aspects of the vascular injury. And especially in the interest of time, I will give my reactions to the talk of by Dr. John Crozier. And I want to congratulate him for an excellent talk. And he beautifully covered the importance of vascular surgery in the austere environment. And I think he beautifully described the austere environment in terms of space, staff, and stuff. And he actually said the space that with reference to the combat environment. So in India, we do see this austere environment in the civilian trauma as well. So there are places that we do see trauma patients with vascular injury, but there is hardly any developed infrastructure, or we are short of staff. There is no trained the trauma surgeons or the vascular surgeons. The stuff, yes, you showed that you don't have the advanced anesthetic facilities. You have only ketamine or midazolam, and the only antibiotic you showed the chronophenicol at times, because we do see more patients with the blunt trauma and with open fractures, and these are contaminated wounds. That whenever we do see a patient with the vascular injury in anywhere in the world, first and foremost, the concept is that you have to do the ABCD. So I just want to make a statement in this regard that injured vessel is typically maybe the only one component of a multi-organ trauma. So you have to see and assess the patient in totality, and these are distracting injuries at times. So I think, and then you beautifully described that in the pre-hospital setting, in the use of tourniquet, and one should not avoid using the tourniquet to save the limb, because with trauma we always say choose the life before limb. And if you want to avoid the tourniquet, use of tourniquet in the pre-hospital setting or in the hospital setting before the transfer of the patient to another facility, you may have a dead patient. The use of the ligation of the vessels, the shunt, yes, I strongly recommend, and I agree with Dr. John, the shunt as a part of the damage control vascular surgery, and especially in the austere environment, it's a savior, because we all know, and the life problem is better than a dead solution. The fasciotomy, yes, fasciotomy should be done liberally, and we always say, when in doubt, do it. If you are confused that I should combine my vascular repair with the fasciotomy or not, I always tell my residents, when in doubt, do it, because you might save a limb. Amputation is a great savior as well. And Dr. John rightly pointed out that especially in an austere environment, when you have to save a life, amputation is the answer. And I like the closer that the situational, one should have a situational awareness. He should be fitness, the core competency, because we all know that one size does not fit all. So you have to tailor your repair according to the different situations, and in the environment you are working, your competency you should know. You should be flexible to modify the paraphernalia you have to manage a patient, trauma patient with a vascular injuries. And yes, of course, the trauma care is a team work. There is no second thought about it. So once again, I congratulate all the speakers and Dr. John especially for an excellent talk. Thank you very much.
Now on to our last reactor. He is Dr. Jihoon Kim. He's the director of Ulsan University Hospital Level 1 Trauma Center in South Korea. He's the chief of the Department of Trauma Surgery, Ulsan University Hospital, South Korea. He did his residency and fellowship training in vascular surgery at the Asan Medical Center, South Korea. And he's a South Korea assistant professor at the Catholic University of Korea St. Mary's Hospital. He's a founding member of Korean Society of Acute Care Surgery, and he will be reacting to Dr. Krahim Bori's talk of extremity trauma, imaging, shunting, and repair. Without further ado, I invite Dr. Jihoon Kim, please.
Okay, thank you very much. Very, very honorable to speak to the professor. So yeah, I'm really agree with your opinion and your lecture. So we usually use the shunt and some kind of the restore the recirculation. So we used to the graft toward the allograft in some kind of that. And then the liberal fasciotomy is also very good method to the restore the perfusion. And then I want to introduce our training course in the first of all. So our training course is 1 year internship and 4 year general course and 2 year special period for the specialty. So we have all the 7 years, 7 year training course is very long time. So we changed it to the 3 year general period and the 2 year special course, and then we have we give the special mode for the specialty. And then I speak about the Ruboa. We have some experience for the Ruboa. The Ruboa is also very useful to the life-threatening, the bleeding patients, especially in the abdomen and pelvic fracture. So in my opinion, in my experience, pelvic fracture is Ruboa is best method to prevent the more bleeding. So I really like the Ruboa to use to the pelvic fracture patient. And then I want to share my slide. I want to talk about the carotid trauma. So we focus on the extremity trauma, but I have interesting to the carotid artery trauma. So I have some experience with carotid trauma. This patient, the lateral lacellation and SM rupture is active bleeding, no active bleeding, airway intact. So we have to check the CT scan, and we found the injury of the carotid artery. And then we have, after exploration, we figure out the intimal injury and the laceration of the carotid artery in the common carotid artery. So we have to perform the endarterectomy and the patch angioplasty and restore the perfusion. As you can see, is a very good flow. And 55 years old for the female patient, traffic accident and multiple fracture, some kind of the multiple fracture. And 2 hours later, the mental change, and he has apnea. So we check the emergency brain scan. The first in the ER, the first brain scan is normal. So, but 2 hours later, we check the brain scan after mental change. So we check the diffusion MRI, the multiple brain infarction, as you can see. So we check the CT scan. We find the carotid artery dissection in the intimal injury. So we perform the carotid artery stenting because of the level is a level 1, level 2, or like to level 1. So it is very hard to approaching the surgical method. So we decide to perform the carotid internal stenting. After stenting, we restore the perfusion. But it is very lack of the evidence because after mental change, after infarction, and even if the 2 or 3 hours later, it is effective method of the neurologic improvement. I have a concern about that, and we have lack of evidence. But we hope to restore the neurologic defect. We performed the carotid internal stenting. Relatively is good the outcomes. And the third patient in multiple stab wound. So as you see, he has internal jugular vein is lacerated with primary repair. And then as you can see, you can see that the black line in the carotid artery. Yeah, so we found the laceration of the carotid artery, but there is no bleeding. So because of the advanced seizure and some kind of soft tissue just stop the blood bleeding. So we exploration is very carefully, and so we can figure out the carotid artery injury. So we have to the reanastomosis of the carotid artery.